Welcome, all pregnant families, midwives or birth workers. This is Tracy Anderson Askew, your host for the Transform Your Birth podcast, changing your mind about birth one story at a time. Each week we will be exploring a birth story through the lens of what birth can teach us. I'll be digging deep into each story so you can learn what it is that can change the way a birth unfolds. We can't control birth, but we can influence it. So listen in to find out how. Enjoy. Today I am talking to Gina Mundy. For over 20 years, Gina has been an attorney that has specialised in childbirth cases that have gone wrong. It has been this experience which motivated her to write the book, A Parent's Guide to a Safer Childbirth. She wants women to use the power of knowledge to help them to make choices that support the healthy delivery of her baby. This is such an important conversation and comes with many warnings of things to be aware of that can potentially be harmful to both mother and baby. An eye-opening conversation that helps us to understand that there is no one way and every decision matters. Please enjoy.
Before we begin, a note from our sponsor. This episode has been brought to you by Transform Parenting, an organisation that provides courses, coaching and community from pregnancy through to the first 7 years of a child's life. Most of the stories you will hear through this podcast are graduates of the Transform Your Birth workshop held in Canberra. Our Transform Your Birth Today course is now available to anyone, anywhere, at any time, and includes all the wonderful wisdom of this course and live weekly catch-ups when you need it with our host, Tracy. For a little taste, please accept our pregnancy gift offer, which contains free the first few lessons and some essential wisdom for pregnancy. The link can be found in these show notes or visit transformyourbirth.com.au. And now for the episode.
Hello, my darlings. It's good to have you again this week. And with me today, I've got a slightly different format today. We've got the lovely Gina Mundy. Gina is from the US. She is an attorney who specialises in childbirth. So she's got some really interesting things to share with us today. And she's the best-selling author of A Parent's Guide to Safer Childbirth. And she's a mother of 3 as well. So welcome, Gina. Thank you for coming.
Oh, thank you, Tracy, for having me. I am very excited for our conversation today.
It's lovely to cross the oceans and cross-fertilise each other. Gina, my audience is largely people who are preparing for birth, and one of the biggest challenges I have in my role is to help people to overcome fears. Now, some fears we can overcome when we know and understand more. Some fears we'll never get over. We have to put those in our pocket. And then there are some other fears where with some good information, we can reframe, we can see things in a different light. So I'm really interested to have you on to talk about some of the things that you've discovered as an attorney, looking at some of those cases that go wrong with your book. So can you just share with us now, what would be some of the most important things you would want new parents or pregnant couples to understand and know in order to avoid, problems?
Oh, sure, Tracy. That's a great question. So chapter 1 of my book goes over all of the lessons from the childbirth cases. The lessons could be from the family, it could be from the delivery team, the medical experts. But as lessons, these are the things that we can learn from the cases to help prevent them from happening in the future. So again, chapter 1 goes over each lesson. And then the way my book is structured, then each lesson is a subsequent chapter. So let's hit a couple lessons. So I always say this is the most important lesson in my cases, from my cases. And just so your audience understands, when I'm talking about a childbirth case as a childbirth attorney, these are cases, that do involve a birth of a baby where a baby was not born healthy, baby may pass, or mom sometimes may pass away, during birth. So these are really important lessons, that we can take from the cases. But the most important lesson is number 1, and that is learning about childbirth, preparing for childbirth ahead of time so that you can make those, important decisions if that's what needs to be, made during labor. And if you have a good understanding of childbirth and what you need to know, I know you offer the course on, the calm and all that. I just think that is
Transform Your Birth course. Yeah.
Transform Your Birth course. And that is just so important to like learn something like that and then learn other things also, because when the families from my cases, they come in, they don't have that knowledge base to make those good, decisions with their delivery team. They just they just roll up and they're like, okay, I'm here to have my baby. And it seems like that's really when, things tend to go wrong because, when you're not prepared and, you just don't know what you don't know. And that can leave you very vulnerable. And I really just, as a childbirth attorney, I just don't recommend it. So if you're prepared for childbirth, you have better communication with your delivery team, more streamlined communication. So, and there's a lot more to that lesson. That's by far the most important lesson, but every chapter kind of builds on that. So then if you go to chapter 2,
And I'll
these
just
are
come
the
in there, Gina. I think what you've hit on there, I think, is one of the most fundamental mistakes that people often make. And it's based on the belief that our carers know what's best for us. And I think it's important with what you've said there. It's important to prepare and understand the process, but even more importantly, to be ready to step up and ask questions of your caregivers and become a part of that decision-making process, because sometimes decisions are made that are not about the couple's, and the baby's best interest. It might be around convenience or, being under-resourced. There can be so many things that happen on the day. So I love that you've raised that as probably the biggest thing to become aware of. Tell us about chapter 2.
So chapter 2 would be kind of like your labor and delivery basics that I find important as a childbirth attorney. So when I get a new case in and I'm looking at the care that mom and baby received during labor, these are like the facts that I rely on to figure out, was this good care? Was this bad care? And, again, this is not stuff you're going to find in a, normal pregnancy book, probably not in a normal pregnancy course. But what I believe to be very important facts that will lay a good foundation to help you make some of those important decisions. Now, the families in my cases are, one decision minutes away from a healthy baby. So making those good decisions, again, is just incredibly important. And you have to understand that as mom, you are the decision maker. Your team, your doctor, your delivery team, while they may phrase something in a way that's like, you're going to have to do this, it's actually a recommendation. Nobody can actually do anything without your consent. And in terms of what you just said with the convenience, listen, sometimes I'm like with OBGYNs, especially the obstetricians, and they deliver babies all the time. I'm like, did they think their profession through before they committed to this? Because as you know, OBGYNs, that's a rough job. This is not 9 to 5, Monday through Friday. Babies are gonna come when babies want to come. These are 12-hour shifts. These are weekends. These are nights. And OBGYNs are like us, they have families. So yes, I've had cases where basically they do stuff. Basically, I'll give you one example, and I believe this is in the book. If it's not, here you go. But I had a doctor, he would do Pitocin inductions and he ran them all the same way. The patients come in actually the night before, they start to ripen the cervix, and then 6 a.m. the next morning, it's just like clockwork. They start Pitocin, he's in by 7. If it's okay, he would rupture mom's bag of water in order, basically, the nurses would say, so he could be home for dinner, is what they would always tell me. So it's very important that, if they're doing a big decision, like, or recommending, hey, I would like to break your bag of water, it's really important that you're like, okay, is there a medical reason that you want to break my water? Or do you want to be home for dinner? And listen, some OBGYNs may be offended. And if they are offended that you said it, that's perfect. Then they're clearly not doing it because they want to be home for dinner. But more importantly, in my cases, and this is another lesson in another chapter we'll probably get into a little bit more, but since I'm here, in my cases, when there is a mistake or there is a complication, it is almost always after mom's water breaks. So in my eyes, as a childbirth attorney, that is a very big decision.
Mm.
So when somebody is recommending it, and it may sound great, you're like, okay, it's going to speed up my labor or whatnot, just have an understanding that when you break the water that's been surrounding baby, surrounding the umbilical cord, which is the baby's lifeline, around the placenta, which is attached to the uterus, which was how baby's been getting their nutrients, that whole intrauterine environment, when that water comes out, completely changes. So that's a huge decision, because in my cases, something may change in there. And when once the water breaks, baby can be more vulnerable to something changing, something happening. So again, very important decision. That's your decision. Your doctor's only making a recommendation, and definitely you want to make sure there's a medical necessity for it, and not just they're trying to get to their kid's soccer game.
Speed up. Yeah, speed up labour. Just giving listeners a bit of an understanding why that can be a problem. If you appreciate the physiological mechanisms behind getting that baby to move down towards the doorway and then eventually through the pelvis, when you break the waters, you can too early in a labour. I mean, waters can break at any time in a labour, and if it happens spontaneously, then that's the path you take. However, if it's done artificially, and particularly too early in the labour, what it can do is predispose babies coming down onto the doorway with a malpositioned head, because the process of that uterus retracting and shrinking typically gets that baby into a lovely tuck dive position so that the crown of their head is presenting, which then molds beautifully. And 9 times out of 10 labour is very straightforward. But if we break the waters too early, we can you're predisposed to issues with sometimes cords and obstructed labour and malpositioned head. So that's a very, very important point. And it does change the trajectory of the labour, because once that baby comes down very strongly on the cervix, it can really ramp up those sensations. That's really interesting, Gina. What else do you think parents need to know?
So chapter 11 of my book are the reoccurring issues, reoccurring facts in my case. So amniotic fluid, breaking the bag of water, that is one of them.
Yeah.
But by far, the number one most common fact, most common issue in my childbirth cases is the drug Pitocin, which you guys call Syntocin.
Syntocin, absolutely. Yeah, Synto for short.
Synto.
Yeah. So this is the drug that we use to induce labour. It's the drug that we use to push labour on. It's also, if it's used a third time, can be the drug that we use to help manage the safe delivery of the placenta, and the theory behind it is to prevent postpartum hemorrhage. But there's a wonderful woman, Sarah Buckley, who's talking a lot. She's done a lot of work on the hormones of labour, and she's talking a lot about the problems with the overuse of Synto. So, Gina, what have you found that would help parents to know under what conditions they might say yes or no to it?
Okay, so that is a loaded question, so I'm going to try to keep it short. But just so your audience understands, I have been involved with the drug Pitocin since my first case in February 2003. I have researched this drug extensively, performed extensive cross-examinations. I know the Pitocin drug insert, or Syntocin, same thing, like the back of my hand. This is a huge part of my cases. So what I did is, yes, this is the most common fact in a baby case. However, then I wrote another chapter 14, on how to have a safe Pitocin induction. Because here's the deal, whether you want a Pitocin induction or you don't, you may listen to this podcast, you may listen to me, you may read my book and be like, I don't want anything to do with Pitocin. No, thank you, doctor. But here's the deal. If you're 38 weeks pregnant, maybe you're not in labor yet, there's a concern for some reason, or you just want to have baby checked out. So you go to the hospital, and for whatever reason, there may be a concern about baby for whatever reason. If you get to the hospital and you're 38 weeks pregnant, the first thing they do is they put the fetal monitor over your belly to check the baby's heart rate. because you got to remember baby's inside you. So they have to kind of figure out how baby's doing. And they do that by looking at their heart rate. It is definitely the best way to see how your baby is doing inside you. But if you go to the hospital at 38 weeks to check on baby, and baby, they're like, there's some concerns. They may do some tests or whatnot. But your doctor may conclude that, hey, we're just not comfortable sending you home at 38 weeks. We think you should deliver baby. Again, that's a recommendation. And the thing is, if you're not in labor, then you have two options. If you agree with your doctor, you have C-section or Pitocin induction. And that, I can tell you right now, is an absolutely huge decision, especially if there are concerns about your baby. So during pregnancy, prior to, even going to the hospital, you need to understand Pitocin and what it does to your body. So Pitocin or Syntocin, like you said, I think you said this, maybe you said in pre-show, so your body naturally produces oxytocin.
Yeah.
So Syntocin would be a synthetic drug, synthetic oxytocin. So that makes your uterus contract. And when your uterus contracts, so baby's inside your uterus and uterus contracts, it squeezes down on baby. And for that time period that the Pitocin or Syntocin is squeezing down on baby, there's no oxygen going to baby. Now listen, nobody freak out. This is completely normal part of pregnancy. Babies, or I should say normal part of labor, babies are literally made to handle contractions. But you got to be careful because when they're artificial contractions, you got to make sure that they're, spaced out accordingly because baby can only handle so much. So natural contractions, way easier for baby to handle. They're made to handle those. But now you have the synthetic drug that's making your body contract. And if your contractions are coming too close or the drug is, your uterus is just like contract, and it's contracting too much, baby can only take so much. And then in my cases, that's really where, baby starts to get into trouble because doctors have explained, and I put it in the book because I do believe it's very important for parents to understand that, when you do have a contraction, it's kind of like baby goes underwater during the contraction and then kind of comes up for air, once the contraction goes away. So with the drug, basically, the way you can administer it safely is slow and steady and hit your sweet spot, okay? Because you don't want to increase it too much. Here's the deal with Pitocin also. It's a very individualized drug. Everybody responds to Pitocin differently. How your body responds to Pitocin, unless you've been on it before, nobody knows. So you got to be very, very careful. You do not stress out baby because that's when the mistakes and the complications, occur. So basically, with when you may need a Pitocin induction, maybe if there's concerns about the baby or, that's something you really have to figure out with your healthcare provider after, you understand the drug and whatnot, and then how to do it safely. Yeah, it's just slow and steady, hit your sweet spot. Once you read the chapter, you'll kind of understand where I'm going with it. But yeah, you got to be careful. You don't want your contractions to be too close because that's how or for too long because that's how baby gets stressed out. But I'll tell you, one of the best ways, if you do have a Pitocin induction, I strongly recommend, especially if you have like a busy labor and delivery team who's kind of running hard, the unit's busy, is to have them place something called an internal fetal monitor. And that measures if that's possible, you learn, that's something you can learn about in the book, if it's possible, because that has to be done after your water breaks. But that will measure the strength of your contractions, and it will definitely measure more accurately how often they're coming. But the most important part of that is that if you have an internal monitor, it's very easy then to determine how baby is doing during a Pitocin induction. So this graph's right next to your bed, the baby's heart rate and the contractions. So the contractions are on the bottom. The baby's heart rate is on the top. There's kind of, you'll see these two graphs. So you look at the bottom, and when you have an internal monitor, the contractions, they look like hills because they're actually, it's an IUPC, intrauterine pressure catheter. So it's measuring the pressure from the contractions. So as you see a contraction go up, if you look at then go to the graph above, which is the baby's heart rate, as long as the baby's heart rate is staying the same during your contractions, assuming that it's a good heart rate, your baby's okay, it's tolerating labor. But as soon as you start seeing, if you're having too many contractions or you've been on Pitocin for too long, and you all of a sudden see contractions going up, your hills going up, and your baby's heart rate's kind of going down at that same time, that may be an indication that baby's not tolerating Pitocin. So, in my book, I go through all of this. I don't know if your audience is like, whoa, listen, everything I said is in much more longer form in my book, because definitely with what I have seen in my cases, if you are undergoing a Pitocin induction as a parent, there's just so much that you need to understand. But listen, too, you're going to be mom in labor. You're going to be in a different state of mind. So it's very important that husband goes through the book. If you go on Amazon and you look at my reviews, I have a lot of husbands on there because, they instinctually do want to protect their baby. They want to protect their mom. And, my book really tells them for the first time, how to do that, how to make sure that mom and baby, go home with them. So if you're like, listen, I want to know some stuff about Pitocin, but give it to your husband. Be like, here you go. You're going to be right next to me. You're going to help me have a safe Pitocin induction.
Yeah. Your caregivers do know this information and should be attentive enough to be making sure that you don't get any more maximum of 3 contractions within a 10-minute period. Because what Gina's talking about is once that contraction's over, the baby needs to reoxygenate and come, it's a good metaphor, come back up for much more air. When contractions are ramped up too hard too soon, then this is the risk that Gina's talking about. Now, there's a couple of things when I've coached people around this, Gina, it's something I do all the time with my induction people, is to help them to understand that inductions work really well if they mimic a normal labour and that it doesn't go up to much too soon. And as you pointed out wisely, every woman's body responds differently. So partners having an understanding, if you've got carers coming in and out and they're not necessarily paying attention, and if the mother's feeling stressed, chances are pretty high baby is as well. So also being able to, the scalp monitor Gina's talking about is a really useful monitor in the sense that they're less likely to lose the trace. A Bluetooth monitor is on the outside of your belly, and I always encourage my mothers to move during labour because they often support the physiological descent of the baby. But Bluetooth monitors are more likely to lose the trace, whereas Gina called it an internal monitor, we call it a scalp monitor, is more likely to hold on to that baby and be very, very clear about whether that baby's stressed or not. Inductions are, our induction rates are very high. It also increases cesarean rates. I think in the ACT, our cesarean rates are up around 41%. I've never seen that in all the years that I've been here. And it's not leading to better outcomes for mums and babies. It's leading to more babies needing help when they're born, which can be a stint in the neonatal intensive care. So these are very, very important decisions, what Gina's highlighting, because they do have a flow-on effect afterwards. So that's the Cinto. So what you're saying then is that a lot of the cases where things haven't been going, haven't gone well, have landed in court, primarily Syntocin cases. Is that what you're saying?
100%.
Yeah.
And I think it's like a cascade effect.
Yeah.
A lot of moms get Pitocin. Now, just so you understand, you did say something important, that the healthcare providers should understand this.
Yes.
Right. So listen, here's the deal, because I talk to the healthcare providers, the doctors, the nurses, the midwives, and I will be like, as a childbirth attorney, I just don't like the drug. It is what it is. It's because of what I do. That doesn't mean that it's right or wrong for patients. That's your choice. You don't know what I know, or what you haven't seen what I've seen to, have that same feeling. But I would say, to my doctors and everybody, I would say, I don't like Pitocin. And everybody universally 100% says, Gina, Pitocin is fine for labor. However, where there's a disagreement and why there's cases is because not everybody agrees on how to administer the drug. That's where they get into trouble. So everybody agrees it's safe. The medical professionals agree it's safe. They do not agree on how to administer it. For instance, I will get a new case in and it'll be, something went wrong. Baby's not healthy. It was a Pitocin induction. I will retain 2 OB/GYN doctors to look at the case, sometimes from the same hospital. So not the hospital that's being sued, but a different hospital. I'll retain 2 doctors and they will look at the medical records of mom and baby. And one doctor, again, these are the experts on the cases. They were not involved in the care. They're coming in to give me their professional opinion. One doctor will tell me that everything was done correctly. They will tell me that the Pitocin was properly administered and whatnot. The second doctor will tell me everything was done wrong. The Pitocin administration was completely wrong. In that same conversation, I remember that one doctor saying they blew the baby out of mom's uterus. And that's one doctor's opinion. And the other doctor was like, nope, everything was perfect. So listen, different doctors, different ways they administer it. You can take chapter 14 of my book and, if you're going over it with your OB/GYN, you're like, okay, well, I'm going to have an induction. I have this attorney that is like, okay, do this, 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 and this. Your doctor may look at chapter 14 and be like, that's how I practice. Awesome. Perfect. I love it. That makes me happy. The other doctors that don't practice like that tend to be more aggressive, those are the ones that may be like, oh, I can. So a lot of doctors, especially in the United States, or the hospital protocols, they've really come down to, Pitocin is not a hard drug to understand the administration. Typically you start at 1 and then they'll go up either by 1. So 1, 2, 3, or a lot of doctors will do, basically go up by 2, 2, 4, 6, 8. I'm definitely a fan of 1. A lot of doctors up it by 2. And I know other doctors can up it by even more. So it just depends. So that's why it's important that you learn about Pitocin during your pregnancy and then have that discussion with your doctor ahead of time. And if you don't and you get to the hospital, then it's actually simple. So a doctor is going to so if you want a Pitocin induction, hopefully you talk about it during the pregnancy so they can write the order according to how you want it. Because again, you're in charge. They're giving recommendations. You don't have to follow it. You can say, no, actually, I don't want to up it by 2. I'd like to start at 1 and see where we go from there. But if you get to the hospital and they're like Pitocin induction, it's very simple. How often are you telling my nurse to increase the Pitocin and by how much? And again, in my book, it just tells you, my recommendation on how it should be. Anyway, if they, just show them my book, throw me under the bus.
It's very interesting that different care providers have different ways of doing things. We often fall into the trap of thinking there's only one way and that there's, very clear protocols around safety for all of these things. But really, a lot of the time, it is a work in progress and it's course correction. And as Gina said, everybody's body responds differently to this substance. Now, here we have midwives administering the Synto or an obstetrician, but typically it'll be midwives who are doing that. So letting them know what your intentions are for the birth. I often talk also to my induction people to let them know that you're hoping to get through without an epidural. Now, one of the things, the traps I think caregivers can fall into is, well, I'll give you the Synto and then I'll give you the epidural and you'll be very, very comfortable. But if the epidural takes away your sensations and you're not aware necessarily of the intensity and just how much that those contractions are ramping up, and your caregiver's assuming you're comfortable, so everything's fine, and we've got the monitor on the baby, so we'll know. But it's still not necessarily doing it in a way that's physiologically safe for your body over the long period of time. We know that it increases rates of postpartum hemorrhage. And so the residual effects of that can be ongoing. And if you've got an epidural, you're not necessarily going to be attuned to that as easily. But I often do say to my induction women, epidurals can be really appropriate with some inductions, but the goal would be for it to be increased gently over time and not to put the mother's body under too much stress, and certainly not to put the baby under too much stress. Gina, we've spent a lot of time on Syntocinon. Is there anything else, any other good advice that you would give to pregnant women in terms of managing and communicating to their carers important information around safety? What else would you suggest?
Oh, absolutely. And just to recap on what you just said with the epidural, in my cases, it is like a cascade effect. It's like Pitocin, and then most do have epidurals.
Yeah.
So listen, moms, I love your approach. And if you can pass on the epidural, that is such an amazing idea. Listen, contractions are hard on mom and baby. So it's important, mom does have the luxury of getting an epidural, but babies don't. So just keep that in mind, because you do want to be able to make sure that, how often they're coming, just feel like what it's doing to your body. I just absolutely love that. And that's such great advice. So going back to my, even the lesson. So listen, your delivery team is so incredibly important, whether it's a midwife, I don't know if you're a teaching institution or you have your labor and delivery nurses, whoever that may be. Many times when you walk into the hospital, your delivery team is really just the people who are scheduled to work that day, and they have such an important job because they are responsible for bringing your baby safely into the world. And, in my cases, it's the delivery team's care that is at issue more than, any other aspect of the case. It's analyzed more than any other aspect of the case. So your doctor will head your delivery team. Now that's the relationship that hopefully you built during the pregnancy, or at least doctors in the practice or whatnot. So, that's another thing that I have done. So delivery teams, I have a whole chapter on your delivery team and what you should know about your delivery team, and think about, even how to, communicate and all that crazy stuff. But OBGYNs, listen, that's been, that's the main person that's who heads the delivery team. Typically, maybe you guys have a midwife, but there should always be like a doctor overlooking it. In my cases, it's typically the OBGYN that's heading the delivery team. Even if there is a midwife at a hospital setting, you still have like an OBGYN, going over the midwife, because obviously that midwives can't do C-sections, operative vaginal deliveries and whatnot. So your doctor will head the delivery team. So I wrote an entire chapter on how to pick the good doctor, because I have analyzed OBGYNs for 21 years. And there's a whole attorney analysis that I do. There's, whenever I have a doctor in a case, there's about 20 questions that we always start off with to try to figure out, that gives me an idea of how the doctor practices. And it gives me a really good idea based upon how they're answering it and talking to me, like, are they a good doctor? But I'll use those 20 questions, at the time of trial, oftentimes to either bolster a doctor's credibility or sometimes discredit a doctor. So these are important questions. So I put them in the book for all the moms. I'm like, here you go.
They love that, Gina.
Go cross-examine your OBGYN. I tell everybody, hey, listen, this is such an important day. For me, since I was a little girl playing with baby dolls, I just remember holding my baby dolls and just dreaming of the day I was going to have my first baby and what my first baby would look like. And then, fast forward to when I graduated law school and I became an attorney. I wasn't supposed to be a childbirth attorney. What happened is I had just gotten married, and having a baby was on my radar because I was always excited to have babies. And it was on my radar, and I get this new job and I'm like, oh my goodness. And I just stumbled on it. I'd never heard of a childbirth attorney. Most people don't even know my profession exists. But, that day when I was hired in to be a childbirth attorney, I was hired into a team of over 20 people. So all we did were these cases. And when I got hired in wide-eyed, like, oh my goodness, wait a minute, I'm about to get pregnant. I want to make sure the birth of my baby goes okay. So, I stuck with it to do it. But anyway, so then doctors, we can now, you asked me a question and then I always start going down all these different trails and whatnot. But yeah,
Well,
no, I think we were on doctors
yeah,
and
you
heading
talked about, and I think this is very valuable to ask it. So there's different models of care here, Gina. It isn't always about obstetricians in our models. We have midwifery-led models that are very, very popular, and tend to be more woman-centered, less medically oriented, and particularly case-loading midwives where they follow you all the way through. That continuity of care tends to lead to the best outcomes. We know that relationships matter. And even more so than that is the independent midwives who do home births. And you get really good care because there's no other distractions. You're her point of focus. So there's lots of different models people could tap into, but we have the private model of care where people will choose their own doctors. And for some women, that's really appropriate. They feel safe with their own doctor. They're getting what they're purchasing there is continuity of a known doctor, which is really important. But it's also important to know that they won't be with you for most of the labour. They tend to come towards the end. But if something gets complex and you know your doctor, that's often very reassuring for some women. Now, when it comes to choosing your doctor, I think Gina's point is very important. Ask your doctor a lot of questions because it is an interview. You are employing them to be there for you. And if there's any ego in the room because you're questioning their professional approach to things, that's a good signal that it's not the right doctor. I don't think there's any space for ego in the room. This is all about everybody working together to get the best outcome for mother and baby and to respect the needs and the choices of the woman so that she can say no to certain things without there being any sort of backlash. And not all doctors can cope with that. Most do, though, in my experience. They're very happy to be more woman-centered and it's more satisfying for them. They develop those lovely relationships, but it's important a woman's voice is heard both in pregnancy and also during the labour. Do you want to give us a couple of questions you'd ask doctors? What would you actually ask?
I know, right? Well, hold on. I have to thank you for bringing my thought full circle, by the way, because I'm like, when I wanted to, then I'm a childbirth attorney because then I have babies and I'm like, why am I telling the audience this?
I should have asked you that question.
Exactly. Tracy brought the thought full circle. I appreciate that.
Yeah,
Now, in the United States, just so you know, it's approaching 6 p.m. And I get up at, well, this morning I got up at 2:30. On a normal morning, I'm getting up at 3 a.m. So I'm only an hour before my bedtime.
You're
So thank you
doing
for
very
bringing my
well,
thought.
Gina.
But yeah, no, but yes, as a decision maker, being your advocate, your baby's advocate, because that is just such an important, powerful day was my point. But Tracy obviously walked you through the last part of that. So yeah, here's the deal with the OBGYNs and what you want to ask them. One of the first questions we ask them during a deposition. So it's always, involved the delivery of a baby. So I want to know, so you got to remember, OBGYNs are obstetricians, people who are, that's obstetricians delivering babies, prenatal pregnancy, or what percentage of their practice is or is obstetrics? What percentage of their practice is gynecology? Gynecology is completely separate from pregnancy. That's all the other women issues. And gynecology, a lot of doctors, as they get older, tend to do more gynecology because the hours aren't crazy. Gynecology, that's like your 9-to-5 job, or it can be. So a lot of doctors, as they get older, go over into this, gynecology, aspect, and then deliver babies almost like it's a professional courtesy, like, oh, you delivered me, a patient may come in, they're just delivering like family members and whatnot. But I always start, I'm like, okay, what percentage of your practice is obstetrics? What percentage of your practice is GYN? So if I have it's obviously a baby, it's obstetrical part that's at issue, and the doctors don't really deliver babies anymore, that's like, you want a doctor who's in the trenches, most days. You want a doctor who's delivering babies because like especially a private doctor and you're in the situation or where I'm not sure how the midwife model, but like you just said, which is so incredibly important, your doctor is typically not bedside with you during labor. They are typically called to come in to catch the baby, do a C-section, or maybe they come right before they go to their office. They may stop in, or if there's a concern, maybe they'll come up there. But the doctor is not hanging out, at your bedside.
Yeah.
So finding out, because they're not, then the people who are by your bedside, the nurse, the midwife, whoever's bedside or communicating with your doctor, if your doctor's delivering a lot of babies, then they're going to have like a synergy together where they know how to communicate, they know each other, and it just works better. If you have a doctor who's mainly doing GYN but delivering some babies, he may or she may not have that good relationship, with the delivery team. And that relationship can be so incredibly important, particularly because your doctor heads the delivery team and they're not there.
Yeah.
So that's a huge one. I always like to know how far the doctor is from the hospital, even if it's their house. So, because we've had a lot of times where the doctor doesn't make it. So they're always like, well, no one called me in time or whatnot. So, I
What about
also,
questions around data, like their statistics, cesarean rates and things? Do you ever ask what?
there are C-section rates.
Yeah.
I do ask them that. I did not put that in the book.
Yeah.
I do. So here in the United States, if they're getting too many C-sections, they get their personal stats from the hospital and they'll get like talked to, but then a lot of those doctors are like, whatever their patient population is, yeah. So I do go over, you ask them specifically, their thoughts on C-section versus vaginal delivery, and how they may respond to something like that. Another super, super important question is, and this actually ties into other things in the book, but where you're going to deliver your baby, is it a teaching institution? So do you have residents? Because doctors do have to learn how to, be an obstetrician, how to deliver babies. And so if you're at a hospital that's a teaching institution, that's a really big deal. And you need to talk to your doctor about that. And how do they talk to residents? Do they teach residents, and whatnot? Another big thing is the baby's heart rate. So again, baby's heart rate is super important. That's going to give you the best indicator on how your baby is doing during labor. So the question for your doctor is, can they review it remotely? Because in the United States, and if you have the Novi, your doctors can they should be able to review the baby's heart rate remotely. But the first question is, can they review the baby's heart rate remotely? And will they review the baby's heart rate remotely without being called? So I have a lot of doctors and everybody here in the United States can review the heart rate remotely, but half of the doctors will only look at the baby's heart rate if contacted by somebody at the bedside. Other doctors seem to stare at it all the time. And as they do, they'll be like, no, if I have a patient in labor, I am looking at that heart rate all of the time. So, you just gotta, I don't know, go through the questions. But to me being a baby lawyer, I would want a doctor who is kind of checking that heart rate out, here and there without so much being contacted.
Well, I think here it would be more the role of the midwife who's on duty at the time to keep an eye on that and to communicate to the doctor if there's any issues around the baby's heart rate. Now, that would involve continuous monitoring, and you'd only want that under certain conditions because it can be very distracting and limiting for the mother. And for the most part, we don't need to check it more than sort of generally what their protocols are in the hospitals around just the midwife checking quickly without disturbing the mother too much. So the continuous monitoring would be monitored by whoever's with you at the time, and it's their job to identify that. What we do know around the evidence with continuous monitoring, though, is it can be very subjective. And so one person might see that, read it as the baby not being happy, and another person might not see that. So even reading the data can be a little bit subjective in that. Is that what you found, Gina?
Oh yeah. I talk about that in my book.
Yeah,
And so it's the same thing with Pitocin.
right.
Now, I'm a fan of monitoring the baby's heart rate. Now, listen, if you're a low risk mom, first baby, you're not on Pitocin, you're trying to be
Yeah,
natural, you don't have your epidural.
yeah,
Hey, that's much better. There's no concerns. You're doing these intermittent checks and baby's
yeah,
okay,
yeah.
whatnot. So,
Certainly with procedures, it would be very important. Gina, we're coming to the end of our session today. What would you like to finish off with in terms of, just give us a little bit of information about your book and any other advice that you'd give to pregnant people?
oh, sure. So a couple of the other lessons, or we'll just say another really important lesson, is to create or prepare a birth plan. Now, my
Yeah.
spin on birth plan is completely different as a childbirth attorney. As you can imagine, it seems like everything that I write is different than your normal pregnancy book. But having a plan, it's more of the act of preparing for childbirth in the comfort of your own home, where you can listen to amazing podcasts like Tracy's podcast. You can read my book. You can kind of entertain these, different options that you may have, learn about them, Google things, do what you got to do to create this plan and understand that when you're creating this plan, childbirth, it's very hard to predict.
Mm.
So, but that's almost why you have to have a plan. That way you can pivot if necessary. So just preparing the plan, getting ready is just incredibly important. Now,
Yeah.
if you want to give it to your delivery team, that could streamline some communication, they'll understand. But if you don't,
Mm.
that's fine. Because again, the purpose of preparing a plan in my world is so that you're ready for the big day. And then that's chapter 6. So that's one of the lessons, have a plan. And then also I go through, just having the baby advocate, just having the second set of eyes. So, your partner or grandma or whoever's at the hospital, they can kind of just be the second set of eyes on you. Because one thing that we did not talk about, which also is very important, is another common mistake or common issue in my cases is a busy labor and delivery unit.
Right. Yeah.
So let me tell you, if you go to the hospital and you're in labor and they're like, okay, all of our rooms are full, but we're going to put you in the extra room.
Mm.
Okay. Just you got to make sure you have an advocate there, somebody to kind
Yeah.
of watch you. And then again, that way mom can just focus on mentally, physically delivering baby. She can relax enough to do so.
Mm. She's in an
So just
altered
having that
state.
advocate there.
Mothers are in an altered state, and they're not always able to take in what's going on around them. So that's absolutely crucial. Thank you so
Right. I
much,
wrote,
Gina, for your time. I'm sorry to cut this off. I've got another session at 10 o'clock, but I wanted to thank you for giving your time to share this important information. We all want our babies and our mothers to be safe during childbirth. And I think Gina's really identified some of the things that can get in the way of that, and to give us a much more realistic sense of the conditions that we're often walking into, in order to potentially head off dramas at the door before they become a big problem for both birthing mothers and also babies. I really appreciate your time. Just tell us what the name of the book is again, Gina, so people can look for it. We'll put it in the show
oh,
notes.
sure. It's a parent's guide to a safer childbirth is the subtitle, Expecting the Best, how using the
Beautiful.
power of knowledge can help you deliver a healthy baby. And all of my information is at ginamundy.com, GINAMUNDY.com. I'm sure it's in the show notes. But
Yeah.
just so your audience knows, chapter 1 of my book is on my website for free. It's downloadable. And again, those are the lessons from the baby cases that every parent should know. So if you know an expecting parent, please go on the website, download it, share it. do whatever you need to do, because no matter what, that is such important information for parents to learn from in order to help prevent mistakes and complications during the birth of their baby.
Beautiful. Thank you again, Gina. I really appreciate your time. And for those listening, tune in next week. We'll have some more goodness for you. Thanks a lot. Bye-bye.
Thank you, Tracy.
We hope you enjoyed this episode. Please subscribe and share this podcast. This episode has been brought to you by Transform Parenting, an organisation that provides courses, coaching and community from pregnancy through to the first 7 years of a child's life. It is a place where you can learn, get support and grow into your role as a parent. Why not take advantage of a special gift for all pregnant women at transformyourbirth.com.au. Or if you have children, we have a gift for parents also.